Hi, my name is David Smith. I'm an orthopedic surgeon. As you know, on our website, boneandjointworld.com, we've been trying to add some informational tapes and podcasts that for folks with joint problems to look at. And I know sometimes when we're talking about joint replacements, the anatomy and what's actually done, it can get a little confusing. When you look at the knee, obviously the thigh bone here, the femur comes down, joins the shin bone or tibia, and then it articulates, or one runs over the other. It's almost shaped like a wheel. It's covered with cartilage. There's the patella that slides up and down. And there's ligaments that hold it together. So let's go from this view, and you can see as you walk, you need to be able to straighten the leg out, and you need to be able to bend it to function normally, to go up and down stairs, to sit in a chair, in and out of your car, and to play any sports. So we'll leave our friend here and go over and take a look at a normal knee with some ligaments attached to it. Ligaments are like ropes that tie things together. They give stability to the joint. They keep it from wiggling around a lot. As you can see, it's two long bones balancing on top of each other. This is the big toe side of the knee. We call this the MCL, or medial collateral ligament. This is the lateral collateral ligament. It's off to the side. So this would be looking at a right knee, a collateral ligament here and a collateral ligament there to give support to this kind of back and forth motion. If we take our kneecap out of the way with the tendons, tendons are where muscles connect to bone. So they have a little different function. Now there's two other important ligaments inside your knee. There's the ACL. You hear a lot of these athletes tearing their ACL. It's this ligament in the front. It prevents the tibia from sliding forward on the femur. And then there's another ligament in the back, called the posterior cruciate ligament, that keeps the femur and tibia in close contact with each other and doesn't allow the femur to come forward on the tibia. These other structures here are the meniscus you might hear about, and they provide cushion to the joint. So what happens when you get arthritis and you finally get to the point where you need some type of joint replacement? And here I wanted to just show that there's a variety of different ways to approach it. A fair number of patients, the arthritis starts in one part of the knee. Most frequently, what we call the medial or big toe side of the knee. And the cartilage on the rest of the knee may look pretty good. So in other words, you may have an area here where it's worn down to bone on bone, and in here where the cartilage is pretty good, and underneath the kneecap where it's pretty good. So there you'd be a candidate for a partial knee replacement. And what that is, it's a resurfacing of the end of the femur, the sort of curved part, with this metal piece of plastic and a metal shell here. Now what's important about that, or why does that seem to work better for most patients? One, you maintain all four ligaments. And these ligaments give you send information to the brain. You may not be getting the signals yourself, but your brain is, and it's giving information back to the muscles as to how to contract the leg to respond to the position. So they give you position sense signals. So they give mechanical stability, but they also give information to the brain about where your leg is positioned at the time. So the partial knee replacements, I find the patients report the most satisfaction. They report a more natural feeling joint than they're likely to with a total joint. Now that's not to say that every partial knee replacement does well or that they're always superior, but in general, if I had arthritis in only one part of my knee, I'd only want that side done. It's a complex discussion. Obviously you need to have it with your doctor, but I just want to introduce that concept to you. So we keep the four ligaments with what we call a uni or partial knee replacement. The other part remains. Now, so let's talk about knee replacement, total knee replacement. What's that mean? Well, there we're resurfacing both sides of the femur, medial and lateral, as well as the tibia, both medial and lateral. And it just looks like a bigger version of our partial. The only thing here, to put this type of what's called a CR knee, cruciate retaining, there's only 3 ligaments left. The ACL, the anterior cruciate ligament, is removed, and what we preserve the posterior and both of these collateral ligaments. So again, that's my next step. If I feel someone needs a knee replacement, I prefer doing a CR over what's known as a PS, and we'll talk about that in a minute. I'm not saying that one's better than the other. I go to a lot of meetings where doctors, I wouldn't say they argue over it, but they discuss the merits of each approach, and there's advantages and disadvantages to both. And just like the partial is not for everyone, the CR is not for everyone. Some patients definitely would be better served with a what's called a PS, or posterior stabilized. We'll talk about that in a few minutes. So again, just to kind of show you what goes on in a knee replacement, we actually make these cuts. And the purpose of them is that when we put the implants in, that the knee is balanced. And we talk about that in some of our other discussions on our website, boneandjointworld.com. So that shows you a little more what a total involves. CR leaves you with 3 ligaments, and again, I think there's some advantage to that in terms of what's called proprioception, knowing where your leg is at and how it's positioned. This is to represent a PS knee. What's the difference here? Only 2 of the ligaments remain. There's one on the medial side, one on the lateral side, but the ACL, which is taken out in this one, is also taken out in the PS knee, as well as the posterior cruciate. Now, the argument there is that some doctors feel strongly that the PCL in advanced stages of arthritis is diseased and needs to be removed, and you'd be better served by giving stability through having this peg articulate and control the back and forth motion to replace the ligament that's been removed. So, put everything back together. So there you have sort of the spectrum. We start with the normal knee, 4 ligaments. The partial knee, 4 ligaments. CR, 3 ligaments. PS, 2 ligaments. And in extreme cases, some people have so much deformity that they need either what's called a constrained device that has a much bigger stem that comes up here that articulates or joins with this. And some patients even need a thing called a hinge. So there's quite a spectrum, but these are the principal ones used most often: partial, CR, and PS. So I hope that answers some of the questions you might have about what's involved in knee replacements. And if you have questions, go ahead and get on our website and let us know. We'll try and address those as best we can. And we'll just show you these models today and see if that helps a little bit.